She's joined by award-winning gastroenterologist, Professor Stuart Bloom. Earlier this year, scientists at the University of Nottingham found that over 500,000 people in the UK live with either Crohn's disease or ulcerative colitis. Today, we're focusing on Crohn's disease, a lifelong condition where parts of the digestive system become inflamed. Good morning, Professor Bloom.
Hi, Caroline.
Nice to have you today.
Thanks for the introduction. Well, as you say, my name is Stuart Bloom. I have spent the last 26 years as a consultant gastroenterologist in the NHS, working at University College Hospitals in London. I'm a clinical professor there. I now spend about half my time in the clinical service at UCH and about half my time in private practice, seeing patients at healthcare, HCA UK facilities, mainly the Wellington Hospital. So it's a great pleasure to be here today to give you a little bit of information about Crohn's disease, which I've spent most of my working life researching into and looking after.
Fantastic. Let's get started with the questions. So how does Crohn's disease manifest? And how do the symptoms affect people's quality of life?
Okay, so that's a pretty open-ended question. I guess we probably should start by saying how common a disease is it? Historically, people haven't liked to talk about it. It's one of the unmentionable bowel-y type diseases, but it's quite common. It affects probably about 250,000 people in the UK. So that together with ulcerative colitis, inflammatory bowel disease probably affects about 500,000 people, which means that maybe 0.5% of people or 0.5 to 1% of people have an episode of inflammatory bowel disease at some point in their lives. So these are not rare diseases. They tend to present in two periods. Firstly, during adolescence and young adulthood, and secondly, during the sort of peak of productive working life, 40s, 50s, that sort of time. So for that reason, they tend to have a very dramatic and often rather traumatic effect on people's quality of life. The symptoms of Crohn's disease are broadly those of abdominal pain and diarrhea. Although, because Crohn's can affect any part of the digestive tract, you can present with mouth ulcers, with epigastric pain, or with bottom pain due to inflammation around your tail end or anus. The symptoms normally come on fairly gradually, so that often we see people who've had symptoms for a year or two, but they can be triggered off by life events, notably infections. If people travel abroad and get some kind of gastroenteritis, that can be the sort of precipitating event. And sometimes stressful life events, or for reasons that we're not quite clear, can trigger it off as well.
Yeah, I think that's really interesting to hear about what a trigger of a stressful event, for example, can start something like an episode or even just the condition. And I think, you hear that saying, you can feel it in your gut. It's really true. Like, stress can really affect people, definitely. Yes. So next question. Is inflammatory bowel disease the same as Crohn's? And what's the difference between Crohn's disease and ulcerative colitis?
Yeah, sure. So inflammatory bowel disease is a blanket term because the bowel can get actually inflamed with a lot of conditions. You can have infections, some medications can cause inflammation. But when we use the term inflammatory bowel disease, we usually, as you say, imply either Crohn's disease or ulcerative colitis. They're the two common types of inflammatory bowel disease. And they're not the same. They're not the same either in the clinical signs or in the science of what causes them. although many aspects of the treatment overlap really. So ulcerative colitis, the clue is in the name. Colitis means an inflamed colon, and ulcerative colitis always affects the large bowel and tends to present with bloody diarrhea. Crohn's disease, named after, by the way, after a physician in New York in the 1930s called Burrell B. Crohn. So he was a bit of a self-publicist and ensured that he was the first author on a couple of the key publications. So although the condition had been described before, his name has gone down in history as being the sort of, one of the sort of the key researchers in the disease. Anyway, as I've already said, Crohn's tends to present with abdominal pain and diarrhea, but it can affect any part of the digestive tract from mouth to anus. Now, whereas ulcerative colitis affects just the lining and mucosa, the internal lining of the bowel, Crohn's disease tends to rather nastily penetrate through all of the layers of the bowel wall. So although it can cause some inflammation of the inside lining, which you can see with endoscopy, it also tends to extend through the bowel wall. And this can result in a rather unpleasant set of events called a fistula, where you get inflammation going from one loop of bowel to adjacent loops of bowel, or even onto the skin. So Crohn's can be penetrating, it can be inflammatory, and then with time, because the body is heroically trying to heal up this inflammation, it can also present with some scarring or some narrowing. So there can be a variety of characteristics with Crohn's that you don't tend to see with ulcerative colitis. So there we are. So ulcerative colitis affects the colon, Crohn's disease, mouth to anus, can present with mouth ulcers, esophageal problems, stomach problems. The commonest place for Crohn's to affect is the last part of the small bowel called the terminal ileum, and the bit of the Crohn's that's just beyond it. So that's the commonest single type. You can, in a proportion of cases, have Crohn's disease affecting mainly the colon, and that's where a bit of confusion arises, because of course that's colitis, but it's due to Crohn's disease, not the ulcerative colitis, really. Does that answer your question? Is there
absolutely? Yeah, that was really good. And yeah, I think it's really important that people are able to differentiate between the two and also understand the nuances between them as well. Definitely. So question number three. What causes Crohn's? Does diet and stress cause it, or are there other risk factors involved?
So this is a question which I've spent many years looking into. So I could talk about this literally just about all day, really. But there are a few really important things to say. If you look in a textbook, or if you ask, historically, many people have described Crohn's as a so-called autoimmune disease that we often refer to like psoriasis or eczema or diabetes. And it is true that there is an association between Crohn's and other autoimmune diseases. But I think we would no longer describe Crohn's as a classical autoimmune disease. A lot of research done in a variety of places can be summarized in, I think, a tendency towards a conclusion that Crohn's is a problem in dealing with bacteria in the gut. There are strong genetic links to this, and many genes which are mutated and which contribute to the tendency to Crohn's. But essentially, what has been found is that I sometimes liken this to the fact that if you're walking around a room and you hit your hand on the door, say, and you cause a bit of a cut, then under normal circumstances, that cut will scab over, and will gradually heal. Yeah. But if you get a bit of glass or wood or contamination in the cut, it'll get infected, and not heal. Well, in many ways, I think Crohn's disease is the same sort of thing internally. Mm-hmm. So minor degree of wear and tear, fish bone or some hot food or maybe a little bit of bacterial infection, which normally you could deal with by processes of bodily healing. In Crohn's disease, something goes wrong with this. So there's a failure of the immune system to eradicate bacteria. And the inflammation that we see is probably a consequence of that. So there's a failure of dealing with bacteria antigens. And of course, that's one of the reasons why the gut is the main site of activity, because of the bacterial load. So we think that Crohn's is a failure of the immune response, and that rather influences how we treat it, because the drugs that we have for Crohn's are anti-inflammatory, but they don't cure Crohn's. They just suppress the inflammation that tends to occur. Ideally, what we'd like to do is cure the genetic defect, which I'm afraid we're still way away from, or alter things so that the body's inflammatory response is improved. And that remains a goal of treatment that we're not quite at. But it does underlie why sometimes we do tend to sort of advise a change of diet. And I think we're going to come on to that in one of your later questions, really. So I'll come back to that in a minute.
Great, perfect. Thank you. So what is involved in Crohn's disease treatment? And is it a combination of, is a combination of diet and medication important?
Well, I guess the first thing in assessing Crohn's disease treatment is to characterize the disease. So we want to know exactly where it involves, and that may involve a few tests, some moderately unpleasant, but usually quite well tolerated endoscopies, either of the bottom end of the gut or the top end, and so a variety of scans, which we're a lot better at now than we used to be, because we have CT scanning, we have MRI scanning, we have ultrasound, and we have a lot of now very sophisticated pill cameras that we can get people to swallow to look at the small bowel and increasingly the colon. So the first step in treatment is to characterize and to assess the disease. Then we have to look into some of the precipitating factors. So there may be some lifestyle factors. So a classic one here is smoking. Smoking's really bad for Crohn's disease. Not in the normal, oh my God, smoking's bad for your health, but something about smoking seems to really flare up Crohn's disease. And similarly, diets, and there are maybe some lifestyle factors as well, because stress can often worsen the symptoms. So there are some sort of holistic things that we might want to look at the overall personal for. But as you imply, the mainstay of treatment is medication, and so there's been a bit of an evolution of treatment in the last, since I've been in practice, let's say the last 20 or 30 years. 20, 30 years ago, we would start with a relatively simple aspirin anti-inflammatory like drug called mesalazine, which we almost never use in Crohn's disease now. And then we would progress through some immune modifying drugs like azathioprine or methotrexate, which, as I intimated before, really work by suppressing the body's immune response to whatever's triggering the inflammation. And then sometimes combine that with steroids, which are they're not good drugs. They act as a sort of like a foam blanket on an electrical fire. They suppress the flames, but they don't put out the fire underneath, really. And in the last 20 or 30 years, we've developed a range of drugs lumped under the heading of biologic medications, reflecting our increased understanding of the inflammatory pathways. And we now have a really pretty impressive arsenal, which is developing, actually. There are many, many drugs in the pipeline, and these can be grouped into different drugs targeting different aspects of the inflammatory cascade. And what's happened is that as time's gone on, we use less and less of the aspirin-like drugs, less and less of the steroids, and actually increasingly, particularly with the pandemic, less immune modifying drugs. And we've moved more and more into using these biologic drugs in an early part of treating the disease. So there are a number of these families. We talk about the anti-TNF drugs, and there's drugs like infliximab, adalimumab. Then there are drugs that target lymphocyte recruitment like vedolizumab and some experimental drugs. And then there are drugs that are involved in the cell signaling inflammation, drugs like Stelara or ustekinumab. And there are some newer drugs in the pipeline. So increasingly, we've got a kind of an arsenal of drugs which we can use, which is very helpful for people with this disease, and which offer much more hope of long-term control, I think, than we used to be able to offer, really.
That's great to hear. I have a friend or a colleague from the past, and he, was brave enough, really, like you were mentioning before about how some people might feel embarrassed to say that they have it. And, he was brave enough to talk about it. And, like learning more about it, you just realize how much people suffer. Their lifestyle is really, impaired by having this. So it's great to know that there's been developments and there's lots of different options, it sounds like.
Well, I'm really glad you brought up the lifestyle issues. I mean, one bit of treatment that I haven't mentioned, but which is unfortunately still required, is surgery. And that can take a number of forms. Curiously, well, not curiously, but I guess interestingly, we now have found that whereas in the past, surgery was like a last-ditch option to treat Crohn's disease, we now find that because Crohn's often presents quite early on, quite localized, and because surgery has advanced so much in terms of keyhole surgery and being much more better tolerated and involving a much quicker recovery, that we can now offer a limited surgical option much more often, and that can really improve people's quality of life. Of course, there are unmet needs in Crohn's disease and situations where it can be really very, very difficult, and where the surgery, where the drugs fail and where surgical operations are required, because sometimes the disease can cause abscesses or situations requiring surgical drainage. The quality of life issue that you allude to is so important because, as I mentioned earlier, it can affect young people, adolescents, at a time when they're building their social relationships. It's really difficult to be able to talk about this disease. It's very embarrassing. It can impact on school life. A bit later on, it really impacts on sometimes employment, financial productivity. It can affect activities of daily living if you've got a lot of abdominal pain. It can affect work life, ability to attend meetings, need to go to the toilet urgently. It can affect social or sexual life. I've already mentioned the financial implications. So these are diseases which affect people at a time of their lives where their quality of life can really be adversely affected. And all of us who are involved in treating people with Crohn's disease know this. Which is why that addressing the quality of life issues is so important. It's not just a mechanistic question of using drugs or surgery. There are much wider considerations, really.
Yeah, absolutely. So final question. Is a low fiber diet important for people with Crohn's disease? I was doing some research and I found this out. So what types of food are part of this diet and how can people integrate it into their lives?
Yeah, it's a great question, and it impacts on the fact that a lot of my patients with Crohn's are now much more involved and see themselves as participating in and directing their therapy much more than maybe used to be the case. So dietary control and the role of diet is really to the fore, really. And there are two big areas here. One is the role of fat. And what we found over many years is that people can't tolerate particular kinds of fat in their diet, long chain fatty acids. It's really interesting. This has come out of a lot of particularly work in Japan, where the diet is much lower fat, higher in fish, and the incidence of Crohn's disease historically was much lower. And then when Japanese people migrate to areas where fat intake goes up, their incidence of Crohn's goes up. And we also have got some laboratory data suggesting that people with Crohn's can't digest long-chain fatty acids as well. So we tend to advise a low-fat diet. In fact, in the kids with Crohn's, they can actually take what we call an elemental or an enteral diet, which is basically a sort of it looks a bit like a protein shake. It's an artificial diet, liquid only, with no real food in it. But because it makes the kids feel better and because it can be flavored, they often love it. And people do adults also will respond to an enteral diet. It's just that they hate not eating solid food. But so a low fat component is really important. And then the other bit, as you say, is fiber. And I actually big this up quite a lot, because especially in people who've lived with Crohn's for quite a long time, where the process of scarring or healing can result in a rather narrow, furred up gut, trying to put too much insoluble dietary fiber, vegetable fiber, is bad news. And the problem here is that we bombard people with the advice about 5 a day. You know, we're always saying you've got to have your fruit and veg and your 5 a day. And for the average person, that's very good advice. But for people with Crohn's disease, it's not. And often too much in the way of dietary fiber is bad news. So you're completely correct. I think a low fiber diet, what that means in practical terms, I tend to say people should watch their intake of nuts, grains, mueslis, often white bread or white rice, is the thing to eat. So you just got to be aware, not too much in the way of uncooked vegetables, avoid potatoes in their jackets, that sort of thing. Although sometimes patients need to actually work with a dietitian to really explore this in detail.
Absolutely. That's really interesting, because I know I was always taught as a child, eat fiber, but there's different types of fiber. You know, it's not just as simple as just saying that and everything's going to be okay. Yeah, absolutely. Okay, perfect. Well, thank you so much. It's been really, really interesting and fantastic speaking to you. I will say, if you're concerned about Crohn's or require expert gastroenterology assistance, visit Professor Bloom's profile at topdoctors.co.uk to arrange a consultation. Thank you so much.
It's a pleasure. Thanks very much, Caroline. Enjoyed it.
Thank you. Take care.